Welcome again, our fourth year medical student, with the part 2 of the first lecture. Today we will talk about two important topics of neonatal intestinal obstruction. These are malrotation of midgut and Meconium ileus. Malrotation of midgut. To understand this disease, first we have to know what is midgut. During the embryonic development of the fetus, the gastrointestinal tract divided into three parts: foregut, midgut, and hindgut. The foregut started from the mouth, esophagus, stomach, duodenum, and the first, second, third part of the duodenum up to the DJ, duodenal junction. While midgut from the DJ, the duodenal junction, jejunum, ileum, cecum, appendix, ascending colon, up to the mid-transverse colon or two-thirds of the transverse colon. While the rest part of the gastrointestinal tract or the anal canal or anus is the hindgut. And you know that the foregut is supplied by the celiac artery, the first branch of abdominal aorta. The midgut supplied by the superior mesenteric artery, and the hindgut is supplied by the inferior mesenteric artery. So our disease is the malrotation of midgut, or abnormal rotation of midgut. During embryonic development, the rapid growth of the gastrointestinal tract will lead to physiological hernia. Physiological hernia, it means that the bowel of the fetus will grow outside the coelomic cavity, outside the abdominal cavity, because the rate of its growth is faster than the rate of growth of the abdominal or peritoneal cavity. فراح يصير physiological hernia, the bowel herniated outside the coelomic cavity in the umbilical cord. And then the second or third trimester of pregnancy, it will return gradually to the abdominal cavity with rotation. بالmalrotation of midgut راح يصير عندي defect بال 3 stages of development. ما يصير complete return of the bowel to the GIT، ما يصير به complete rotation، فراح يصير عندنا abnormal position of the two limbs of the midgut. احنا عندنا two limbs of midgut اللي هي two point of fixation of midgut DJ و cecocolic limb, as we see in the next slide. This is the normal development of the midgut. 2 point of fixation of the midgut, duodenal junction here in the left upper quadrant of the abdomen, and the cecocolic limb in the right lower quadrant of the abdomen. In between them there is a broad base fixation of the mesentery of the small bowel, broad base. ما في risk of twisting or volvulus. بينما من يصير عندنا malrotation of midgut راح يصير عندنا abnormal position of the cecum, abnormal position of the duodenum, duodenal junction و cecocolic limb واحد قريب على الثاني، ما صاير بيهن proper fixation، وأكو فد band peritoneal band fold of fibrous tissue passing from the lateral wall of the cecum, crossing over the second part of the duodenum into the posterior abdominal wall. هذه نسميها band of Lads or Lads band. ممكن يسوي external compression على الduodenum. أيضا راح يصير عندنا mesentery of the small bowel is a narrow base، مو مثل النورمال هنا broad base. هذا narrow base mesentery. in between them يمكن يصير هذه المدقت كلها اللي هي هذا بقية الديودينم، جوجينم، الإليوم، الحد السيكم والترانسفيرس كولون، كلها بها risk of twisted، يصير بها volvulus around this narrow pedicle، narrow base of the mesentery، واللي من هذه narrow base of mesentery يفوت superior mesenteric artery اللي بيه كل البرانشز اللي تنطى سبلاي للمدقت. هذه abnormal rotation of midgut مثل ما تشوفون، السيكوكوليك limb والدي جي one near the other، وهذه السمول باول كلها مشتركة بنارو ميزنتري، superior mesenteric artery يفوت منها ويسوي سبلاي لكلها، بها risk of volvulus. هذه هنا تشوفون صار twisting of the midgut، صار بها volvulus مفترة، وصار interruption of the blood supply of the whole of midgut. as you see in this picture, intraoperative picture، هذه نسميها volvulus of midgut twisted. Presentation of malrotation of midgut. Either it will present with volvulus, نسميها volvulus neonatorum, واللي هي top emergency. We have to explore the baby immediately without waiting, even without sending the baby for investigation, because the delay in the intervention, the surgical intervention, a few hours, يعني إذا أخرنا للبيبي 8 hours or 12 hours, we may find gangrenous of the whole of midgut من الديودنوم لحد ال 2/3 of transverse colon كلها راح نلقيها ischemic و gangrenous و dead، لأنه احنا مثل ما قلنا الفولفولوس راح يصير interruption بال blood supply of the whole of the small bowel. superior mesenteric artery كله يصير به interruption. Or the other presentation is partial duodenal obstruction. هذا يصير on off، يعني partial obstruction of the duodenum، يصير twisted partial twisting وبعدين يرجع ينفتح. incomplete obstruction of the duodenum or volvulus devolvulus، torsion detorsion، فيجي recurrent attack of bilious vomiting. أو ممكن البرزنتيشن ماله يصير على شكل chronic non-specific abdominal complaint، هذا يجي at older age، أو ممكن يكون asymptomatic. يعني إحنا may discover إنه ال patient عنده malrotation of midgut during surgical exploration during laparotomy for another disease, incidentally finding. Diagnosis of this problem by sending plain abdominal X-ray or doing upper gastrointestinal study، واللي هي diagnostic confirmative diagnosis. As you see, this is barium meal، يعني contrasting the stomach with barium follow through contrasting the small bowel. This is upper GI contrast study، barium meal and barium follow through. The abnormal finding in this X-ray is that there is no typical C-shaped configuration of the duodenum, and there is abnormal position of the DJ junction. هذا الستومك وهذا البايلوريك canal، وهذا المفروض C-shaped configuration of the duodenum. المفروض DJ duodenal junction يصير to the left side of midline، هذا الميدلاين. المفروض هنا يصير duodenal junction، اكو ligament of treats يسوي fixation to the posterior abdominal wall. هنا DJ صاير to the right side of midline، to the right side of midline، وماكو في typical C shape of the duodenum. بالعكس ال fourth part of the duodenum صاير more inferior than the usual position. نلاحظ ال small bowel كلها distributed in one part of the abdomen. هذا إذا أخذنا another review بالباريوم meal barium follow through، راح نشوف ال small bowel كلها متجمع هنا والlarge bowel متجمع بالجهة الثانية، و abnormal position of the duodenal junction. أو ممكن نشوف corkscrew appearance of the duodenum. This is the duodenum twisted around itself، صاير ب partial obstruction or volvulus of the midgut. هذا الستومك وهذا ال NG tube nasogastric tube، وهذا ال duodenum صاير مثل ال spring shape or corkscrew appearance. Treatment. It is top emergency, as I said. We should explore the baby immediately without waiting the investigation. The typical presentation of the volvulus neonatorum هو أنه يجينا للنيونات healthy أول يوم يومين، بعدين يصير sudden onset of bilious vomiting with or without abdominal distension and passing blood per rectum، bleeding per rectum. يقول لك البيبي أول يوم يومين كل شيء ما بيه healthy وياخذ feeding وباس motion وباس meconium، بعدين suddenly crying، abdominal distension، repeated vomiting ويصير bilious vomiting and passing blood per rectum. This is a plain abdominal X-ray نشوف abnormal finding feature of intestinal obstruction، وإذا كان عندنا time نسوي contrast study it will be confirmative. But if we have suspect the baby have malrotation of midgut, we should explore immediately without waiting the investigation, because the delay it means death of the baby. After doing resuscitation, we do LADS procedure. LADS procedure هي procedure for correction of malrotation of midgut, and it consists of the following steps. First, after exploration راح نلقى الباول المدقت كلها dusky ischemic congested، ممكن نلقاها gangrenous، ما عندنا غير انه نسوي لها resection or wait and see for 24 hours after detwisting. وممكن نلقاها بس صاير بيها volvulus بعد ما صاير بيها ischemia وgangrene. الفيرست ستيب detorsion devolvulus، نسوي correction للvolvulus by rotating the bowel counterclockwise إلى أن ترجع ال blood supply ويرجع ال pinkish color of the bowel. هذا ال procedure of detorsion. Later on we have to divide this band اللي هي abnormal peritoneal band lads band، نسوي لها division to free the duodenum لأن كانت مسوي obstruction على duodenum freeing the duodenum. بعدين نسوي redistribution of the bowel بحيث ال small bowel تتجمع ب one side of the abdomen وال large bowel تتجمع بال other sides of the abdomen. بعدين نسوي incidental appendicectomy. appendix we should remove it لأنه السيكم راح يكون عندنا بال other sides of the abdomen وراح يبقى بال right side of the colon بال right lower quadrant. فحتى لا يصير misleading بال diagnosis of acute appendicitis in the future we have to do incidental appendicectomy. These are the steps of Ladd's procedure for malrotation of midgut: exploration, evisceration of the bowel; detortion of the bowel; division of the Ladd's band; widening of the mesentery and redistribution of the small bowel on the right side or large bowel on the left side; incidental appendicectomy. The other topics is Meconium ileus, autosomal recessive disease, systemic affecting the GIT, gastrointestinal tract, hepatobiliary and respiratory, and have pulmonary complication. Cystic fibrosis, first presentation 15% of them presented in the neonatal life as neonatal intestinal obstruction, what we call it Meconium ileus. The disease have abnormality in the exocrine mucus secretion بسبب إن mechanical intestinal obstruction. As you see here, this is the small bowel, distended terminal ileum because of intraluminal mass of meconium obstructing the terminal ileum. So it is not an ileus, it is misnomer, wrong name, because you know the ileus is mean no peristalsis, loss of peristalsis, but here we have a mechanical intestinal obstruction because of abnormal composition of the meconium. The exocrine part of the pancreas didn't secrete enough amount of pancreatic enzyme, so the meconium have abnormal composition. Decreased amount of water, decreased amount of enzymes, increased amount of protein on the mucus, so the meconium here will be extremely tenacious, thick or stony hard, causing obstruction of the terminal ileum. As you see here in this intraoperative picture, the ileum distended, dilated, with intraluminal obstruction with terminal ileum. This is the pupils of the meconium. It's very hardly to pass through the meconium, even of the strong peristalsis of the bowel. So it is mechanical intestinal obstruction. In the presentation, we have either simple Meconium ileus, which can be treated by conservative treatment medical management, or complicated Meconium ileus. It means causes complication and the surgical intervention. These are either volvulus, because the bowel will be heavy in one part of the bowel loops, may cause volvulus around itself, or causing intestinal atresia. And if you remember, it may be associated with type 3A intestinal atresia, Meconium ileus associated with this type of intestinal atresia, cystic fibrosis with type 3A atresia, or causing intestinal necrosis as a complication, or may cause intestinal perforation, whether intrauterine perforation or after delivery with the spillage of meconium outside the bowel. And lastly, meconium peritonitis. All of these are indication to do surgical intervention. The diagnosis usually by plain X-ray, which may reveal non-specific finding of neonatal intestinal obstruction, just gaseous distension of the bowel, distended small bowel, with no specific finding or no specific clue to the diagnosis. Or we may see a soap bubble appearance, one of the signs of neonatal intestinal obstruction. Radiological signs, soap bubble appearance. هي الكونديشن الوحيدة of the intestinal obstruction اللي يصير بها air fluid level so bubble appearance, because the air when mixed with the meconium ما ينطينا air fluid level, ينطينا what we call it so bubble appearance. And if we do contrast study, we will see the specific sign ground glass appearance. We may see a speckled calcification of the meconium in the peritoneal cavity. هذه calcification of the meconium in the peritoneal cavity. Contrast enema. If we use contrast enema, we may see a narrow caliber colon, non-used, disused, and there is a filling defect. Filling defect, it means non-occupied by the contrast study. Pupils of meconium in the terminal ileum and in the colon. So a filling defect وهو narrow caliber, small caliber colon collapsed. This is the arrows indicating the small caliber colon. يعني يشوف يقول هذا small ball بس بالحقيقة هو هذا colon. الكونتراست study اللي مستخدمين هنا هو باريوم انما، يعني instillating the dye through the anus. وراح نشوف هنا filling defect اللي هي ما ماخذ الكونتراست because of the content of the meconium. Abdominal ultrasound, we may see the finding of ascites, ascitic fluid, or we may see abdominal mass. اللي قلنا عليها ممكن نشوف الميكونيوم pseudocyst formation. هذا الماس of meconium بتجمع البريتونيال cavity. We may see calcification of the meconium by the ultrasound. Treatment. The treatment of this condition according to the type. After resuscitation, as we said, for the nasogastric decompression, IV fluid, electrolyte, antibiotic, we decide either to start for observation, conservative treatment, and non-operative treatment. For the simple type, not complicated, يعني نستخدم الجاسروغرافين اللي هو ميجلومين diatrizoate water soluble material، نستخدمه for the diagnosis and for the treatment، يعني diagnostic and therapeutic. orally نستخدمها ننطيها للبيبي، تسوي لنا osmotic liquefaction of the meconium وتسهل ال passage of the meconium per anus. multiple sessions، وياها نستخدم IV fluid ونعيد للإكس راي ونشوفها. هذا ممكن يفيد من 85% من الكيسز of meconium ileus إذا كان simple not complicated. أما إذا صار عنده واحدة من complication of meconium ileus فdefinitely يحتاج operative treatment exploration, and then the treatment will be according to the finding. We may do resection and stoma, we may do resection anastomosis, we may do intraoperative liquefaction of the meconium. We have different types of surgical options for the treatment, either to do meculex enterostomy, 2 bowel loops adjacent to each other, inverted as a stoma, one for decompression and passing meconium and stool, and the other one for irrigation of the distal bowel and liquefaction of the meconium. أو نسمي البروسيجر الثاني بايشوب كوب, end of the proximal bowel anastomosed to the side of distal bowel, والدistal bowel نطلع على شكل distal chimney as a stoma. هذا هم تفيد for decompression for irrigation of the bowel. هذه هي the best procedure لأنهم تسوي لنا high output stoma. العكس مالتها هي Santulli blank procedure, side of the proximal bowel with the end of distal bowel نسوي لها anastomosis وبعدين البروكسيمال نطلعها على شكل stoma. أو ممكن نستخدم just tube enterostomy، يعني نخلي tube بالباول نبقي fixation هنا temporary for 3-4-5 days for irrigation of the bowel with normal saline، أو نستخدم N-acetylcysteine يساعدنا على liquefaction of the meconium. هذا كلها surgical treatment temporary. Later on after resolution of the problem, once the bowel opened بعد ما كفد anatomical obstruction راح نبدي oral feeding للبيبي، ونستخدم هنا لازم نسوي supplementation of the pancreatic enzyme lipase، لأن ذول عندهم defect بالpancreatic enzyme lipase، نستخدم له pancreatic enzyme lipase with the milk. Later on we have to follow the baby for the rest of the complication, pulmonary complications and others. This is the end of these topics for the lecture 1. Thank you for your attention, and I'm ready for any questions. Thank you.